Our next speaker will be Dr. Mayur Dutta Bharali is a young dynamic phacosurgeon from Guwahati and Nalbari too. His topic is higher end biometry results, figure out and managing.
Thank you, sir. Thank you, sir. So thank you, Surajbutta sir, giving me this opportunity to be part of your instruction course. After wonderful video presentations by Dr. Manas, my topic will be slightly theoretical topic, but still important. So high-end biometry results. I have no financial interest or affiliations with any of the biometry platforms I will be speaking on. So no talk on cataract surgery is incomplete without at least remembering when Harold Ridley first implanted the IOL, getting very high refractive surprises. Then in 1970s with the development of A scans, then also in 1980s started giving the emetropia IDEM lenses, and finally we are now using all those theoretical formulas different. But from those 1970s to till now, our search for residual zero is still there, because all patients need near perfect visual outcomes, and this necessitates a highly accurate calculation of the IL power. Now the shift is moving from a satisfactory vision to the refractive perfection. But the problem is that even with modern Swepser's OCTs, still 20 to 30% eyes fall outside with a refractive surprise of plus minus 0.5 diopter. So therefore our goal is to identify those 5% of the nightmare eyes. And what are those nightmare eyes? Are the difficult or extremes of the axial lens, short axial lens less than 22 millimeter and long eyes with more than 26 millimeter. So let us first talk about these high myopia or long eye challenges. Cataract surgeons now face several challenges when calculating the IL power in patients with extreme long eyes, because with axial and overestimation and posterior staphyloma. The challenge is, why do we struggle in these eyes? Because it is a trifecta of trouble. First, the anatomy. A posterior staphyloma is not just a bulge, but it's a trap for us. And if our A scan hits the slope of the staphyloma rather than the fovea, our axial length complete calculation is wrong. The second in the trifecta is the effective lens position, because this effective lens position is it's like a moving target in a big eyeball. And finally, the hyperopic surprises we get, because historical formulas were optimized for the average 24 millimeter eyes. But when we stretch these old linear formulas to the bigger eyes, they consistently underpower the IL powers. So how do we get a perfect scan? So actually, Swepser's OCT is the gold standard. The beauty of this technology, like IL Master 700 or the Argos, is the fixation checks. We can physically see if the patient is looking at the target or not, because these high myopic cases have the very, very poor vision. And it is not the wall of the staphyloma instead of the foveal pit. So fixation check is very important, and we get that with Swepser's OCTs like the IL Master 700. And if at all in hard cataracts, very thick posterior subcapsular cataracts, or the mature hard cataracts where IL Master 700 or these optical biometers fail to work, we have to use ultrasound biometry. Then immersion is the best, because with 1.1 mm error in the axial length also, around 0.25 diopter of error we get. So after getting the results, analyzing is also important, because in these big eyes with big vitreous cavity, the signal to noise ratio is very messy. We'll get different spikes. Whether it is from the retina or from the vitreous, we don't know, so we have to analyze it also. And then high myopes often have a flatter corneas, so we have to ensure the K readings are consistent in the both eyes. If the inter-eye symmetry is more than 3 millimeter, to repeat the scans also. So now coming to the formulas which need to be used in these long eyes. Like the Kane formula, it is AI based, currently considered the most accurate in axial length more than 26 millimeter eyes. Then Barrett's Universal 2, it's excellent reliability, and many of us are using. Then comes the Hill RBF AI based, data driven. Then the newer ones like the emetropia verifying optical EVO. These are very robust in avoiding the hyperopic shifts in high myopes. And if at all we have to use the older formulas like SRK-T or Holiday 1, we have to have a Wang coach adjusted axial length. And what is that Wang coach adjustment is that normally these older formulas, what concept is that they think the eye to be very long, and so we use this adjustment to linear non-regression formula, and we decrease the axial length. In a newer formulas like Kane or Barrett, it is already incorporated in it. But if at all we have to use the older formulas, then we have to take this adjustment and take a corrected axial length. So finally, concluding in these high myopic eyes, we have to validate the axial length with this SSOCT with foveal fixation checks. We have to avoid SRK-T in favor of these universal to newer formulas, and we always have to under-promise and over-deliver in case of high myopic cases. So I'll not go into the surgical planning. Then next difficulty is the short eye or the high hypermetropia cases. Short eyes with high hyperopia continue to present a special challenge with regard to the biometry calculation, because these are very crowded eyes. The ultrasound axial length determination becomes very difficult. And also it is very difficult to know the exact effective lens position where finally it will sit, the lens will sit in a very short eyes. So this effective lens position is the holy grail in short eyes. So crowded anterior segment with shallow ACD makes it harder for formulas to find the final resting place. 0.1 mm error in predicting where the lens sits causes 0.5 diopter of shifts. Also in case of in short eyes, this 0.1 millimeter error in axial length also results in about approximately 0.75 diopter to 1 diopter reflective error. So the formulas to be used in these type of eyes are the Haggis, Hofer Q, Holiday 2. Because accurate IL power calculation requires normally these factors are required: axial length, anterior chamber depth, keratometry, and lens thickness. This is all the more important. All these short eyes, minor measurement inaccuracies, it can result in disproportionately large postoperative refractive errors. So how to minimize these refractive errors in axial length less than 22 millimeter on short eyes, myopic surprises. Older formulas like Hofer-K traditionally overestimate the space available, often leading to the unintended post-op myopia. Then again, SWEPS or OCT is preferred. The ACD is very critical in these short eyes, and also modern formulas because these modern formulas use this ACD to predict the ELP. So formulas are like Kane formula, Barrett Universal 2. Hofer-Q is the gold standard in short eyes, but now is often outperformed by because AI is the flavor of this season. Hale RBF, data-driven and AI-based, because of the presence of large language models. Now we have big data, so they give us better results, and the Olsen formula. To summarize, Barrett's Universal 2 is a gold standard for its versatility. Hale RBF, artificial intelligence driven, very good. Kane formulas are also leading in many independent meta-analysis to give accurate results. Then Olsen formula, because it excellently precise, excellent when precise ACD and lens thickness are available. Now, a quick line, you have time? Sorry. So a quick line for this emetropia verifying optical formula. This is online available. This is developed by Dr. Tun, and it is good for us because it don't require high-end gadgets. It is available freely with EVO calculator, and you can get the results. Calculating the best intraocular lens for patients undergoing cataract surgery remains the key part in achieving patient satisfaction. Over the past decade, significant progress has been made developing methods to adjust the axial lens, which have improved the prediction and accuracy of IL formulas. Finally, despite these constant advances in biometry and ever-improving power calculation formulas, we are still only getting about 80%, 80 to 85% of patients with 0.5 diopter target refraction. Thank you.
Thank you, Dr.